Hello and welcome back to the channel. You join myself, Dr. James Gill, for another clinical skills video. Today we're going to do the deep dive into the abdominal exam. So in terms of starting off with the abdominal exam, observing the patient is going to be a very key feature, both them walking into the room and as they're sat at rest in the bed. Does the patient appear to be agitated? Can we notice any issues, perhaps suggesting that they may have problems with hygiene? For example, is there a smell? Does the patient look kempt or unkempt for that matter? Again, obviously with an abdominal examination, we don't want to prejudice this, that we're dealing with alcoholics, etc. That is very much not the case. But we do need to be aware of what features we may see if a person is perhaps prioritising alcohol as opposed to other parts of their life, which unfortunately can be seen. Now, I highlight that because when we are dealing with patients that have a disordered use of alcohol, we do need to consider them as a whole person. And part of that may be looking at their blood tests subsequently to see whether or not they're getting adequate vitamin intake. Again, it's very common that patients will not be getting adequate nutrition when they are consuming large quantities of alcohol like that. So, as mentioned, we're going to have a look at the patient. Here, the patient seems calm and rest, and with no obvious issues. Again, we can have a look briefly over the face to see if there's anything like a plethoric facies, so any redness to the face, any obvious signs of telangiectasia to the mouth. So, we obviously need to make sure that we've gelled our hands in all patients, and at that point we can confirm the patient's details and confirm they're happy for us to do the abdominal examination. So could you please confirm your name and date of birth, please?
David Rogerson, 16th of the 10th, 92.
Okay. And in terms of this, we're going to abdominal exam we've been asked to do. That's going to involve you taking off your shirt. We'll have a look at you as you lie there on the bed, also having a look at your face and also palpating around your stomach, as well as listening to it and getting you to do some special movements in terms of us pressing around on your stomach. Is that okay?
That's fine.
Super. So if you could start off by taking off your shirt. And again, we have the opportunity to observe the patient as they're sat calmly at rest. And that involves obviously looking at the patient's overall body habitus. Can we see any abdominal scars? Can we see any spider nevi, so small dilated veins on the chest that may indicate that there is an issue with the liver? Particularly because spider nevi are associated with high estrogen states, very similar to the palmar erythema. It's acceptable to have up to 10 spider nevi between the front and back of the chest. However, if we get more than that, then we do need to consider what may have caused those. One of the things that could, as mentioned with high estrogen states, the patients who are pregnant. Obviously not going to be the case here, but it's something that we need to keep in mind when we're assessing female patients, that there may have been something, a pregnancy, that's brought the spider nevi to the fore, which is now distinctly in the past. And we can identify spider nevi because although they look like star-shaped blood vessels, if we press the central vein wall, then the blood vessels will blanch and will refill from that central area. It's actually quite an impressive thing to see. I remember them from medical school. I was always very pleased when we found them. We also want to, particularly on chaps, assess the pectoral muscles to make sure there's no evidence of gynecomastia, which again may be associated with deficiencies of the liver to be able to break down and filter these hormones. Because yes, in the same way that women have a small amount of testosterone, men also will have a small amount of estrogen, which tends to be produced from the fat cells of the body. So hence why gynecomastia can be more evident in patients that have a high body fat mass. And raise your arms up for me. Okay, so as the patient's got their arms out initially, I'm trying to see if there's any signs of a tremor, which there isn't. And if you could cock your wrist back, please. And here we're looking to see if there's an asterixis, a liver flap, which may indicate a cerebellar issue, for example, with alcohol intoxication or liver disease. So when we're having a look at the patient's hands, we want to have a look at the nails to see if there's any leukonychia, so any white spots. We've got a very small one here, but the commonest cause for those is trauma. We want to see if there's any spoon shaping of the nail, any cholonychia, which would indicate an iron deficiency anemia. We can also have a look to see if on the opposite side of the hand, please. So looking over the palms, we want to see if there's any redness to the palms, so palmar erythema, which we can see with liver disease, we can see in pregnancy, in high estrogen states, and also patients with obesity sometimes. So we also want to palpate over the palmar surface to see if there's any thickening of the aponeurosis that we may see with Dupuytren's contracture. Dupuytren's is associated with alcohol intake, is also run in families, so we know there is a genetic component, and it was thought, but hasn't been substantiated, that it was related to the use of heavy machinery, but that hasn't been substantiated, as I say. If you could put your fingers together like so, please. And we're having a look to see if we can see this diamond-shaped hole between the two fingers, suggesting that we don't have signs of clubbing. We then need to move on to the patient's face. So we can get them to pull their eyelids down, so if you do so for me. And we're having a look inside to see if there's any anemia, so thinking about that patients may have bleeding from the bowel. Maybe we're looking at things like celiac, where they're not absorbing iron well. Maybe, again, as we mentioned, issues with alcoholism. Maybe the patient has a poor diet. Either way, if we can see that pallor to the conjunctiva there, we know that we've got to dig deeper. In terms of the eyes as well, we get the patient to look down while pulling their eyelids up. We want to have a good look at the sclera there, so paying close attention to the whites of the eye. Now that's important because we may here see jaundice, a yellowing, which is due to an increased bilirubin buildup. That can often be present in the skin. Somebody may come in looking slightly jaundiced, or perhaps more importantly, mentioned that they're looking slightly yellow by a family member. But the change to the sclera, that kernicterus, is the first thing that we may see. Whilst we're looking in the eyes, we also may see a Kaiser-Fleischer ring, or a copper-coloured ring, indicating Wilson's disease, which can lead to raised levels of copper in the liver and can cause significant neurological issues. Moving down the face, we need to have a look at the mouth. So starting off with the lips, can we see any problems to the sides of the lips, suggesting perhaps cold sores or fissures, which may be associated with B12 deficiency. We can see the difference between a B12 deficiency causing fissures and our cold sores, as the changes with the cold sore will give a vesicular appearance, which won't be present with that B12 deficiency. We can also check to see if there's any telangiectasia, so red marks on the lips, which may suggest that there are potential sources of bleeding then throughout the GI tract, because telangiectasia can be found throughout. If we could have a look at your tongue, please, and show us your tongue. Okay, so there's no signs of glossitis, there's no inflammation nor anemia there, which we would have also seen with the pale conjunctiva. Does the tongue look smooth and red, so a big, red, beefy tongue that we're going to see with a vitamin B12 deficiency? And if we could see your teeth, please. Okay, and there's no problems with the dentition, there's no bleeding gums. That's fine, thank you. Okay, and also just underneath your tongue as well, please. Okay, so having a look at the teeth, we're checking any signs of problems with the dentition, which may indicate problems both with perioral health with regard to hygiene, but potentially also issues, for example, with gingivitis or gingivitis, where we have diseases of the gums. Similarly, we're having a look around the sides and under the tongue to see if we can see any signs of mouth ulcers. Now, mouth ulcers, aphthous ulcers, can be very common, and I would imagine everybody watching this video has experienced them in the past. Single ulcers which resolve aren't an issue. However, recurrent, many ulcers in the mouth are a source of concern. Are we considering an inflammatory bowel disease, such as Crohn's, which will affect mouth to anus, Or could we be looking at something more sinister, for example, such as Behçet's disease, another autoimmune disease? We then need to have a look at the neck, so checking for our lymph nodes. So if we get the patient to sit up, please, and swing your legs over. We must make sure that we're examining the lymph nodes from behind, so with the patient sat up. I'm then going to make sure the patient is aware that I'm going to approach them from behind, and they know I'm going to put my hands on their neck so as not to be alarming to the patient. So I'm just going to start off examining your neck from behind, and I'm going to start off with the chin and move back to your neck. Is that okay?
Yep.
So we want to review all the head and neck lymph nodes, starting off with those under the chin, the submental, moving along the sides of the jaw, the submandibular, to the tonsillar and parotid. We're going to go up in front of the ears to the preauricular and the postauricular behind, and then the deep and superficial chains on the neck. And at this point we need to get the patient to shrug their shoulders up and forwards and pressing down with our left hand in the supraclavicular fossa to see if we can see Virchow's node, which can be associated with GI malignancies. We also want to press over the front of the clavicle to make sure there's no evidence of lymph nodes there. Sometimes people will also examine the axillary lymph nodes in the abdominal examination, but it's an area that I would only assess if we found other lymph nodes suggestive of that. So if you could lean back on the bed for me. So we need to continue assessing the neck, and we're going to do that by looking at the JVP. So if you could relax your neck back on the bed for me. So in terms of finding the JVP, we always need to get the patient to relax their head back. And if you could turn to the left for me. So we can sit, if you just sit forward slightly. There we go. So if the patient's head is not relaxed, then the sternocleidomastoid muscles become contracted and we can't see any pulsation here. So relax back again for me. And as soon as they relax, they disappear. The JVP is essentially a manometer of the heart. It gives an idea of what's going on in the patient's right atrium in terms of pressure. So there are multiple things that may cause a raised JVP, but from an abdominal perspective, we're going to essentially be focusing towards liver failure, cirrhosis of the liver that may be affecting the blood supply coming back. Now, we're measuring the JVP from the manubrial sternal height upwards with a sort of an imaginary ruler. So here we can see a slight pulsation. The crucial thing with the JVP to separate it from the carotid pulse is it palpable? So I can't feel that pulsation there, so it's likely I'm looking at the JVP. And we're looking for it to be normally below about 3 to 6 centimetres. And I can see a pulsation here, which is about 2 centimetres, so I'm not concerned. But to confirm we do have the JVP, I'm going to make sure there's no pain on the patient's abdomen, and I'm going to press up into the abdomen, forcing blood up from the liver, up the internal blood vessels through the JVP. So do you have any pain on your stomach?
No.
So I'm just going to press in, 1, 2, 3, up and in. There we go, so nice rise there with the JVP. Now in some patients we won't actually see the JVP risen at all. So for example, a patient with liver cirrhosis, in which case it could be that the JVP has gone so high up into the skull and thus we can't see it here, and we do the hepatojugular reflux and again we can't see it. But what we may see is we may see the earlobe waggling with each beat, in which case suggesting that they've got an incredibly high JVP. At this point we can get the patient to sit forwards for me. And we're going to lie the bed flat, and again have the patient lie all the way back. If you can relax your hands by your sides, it's very important the patient's hands are by their sides rather than up behind their neck, because we want the abdominal wall to be relaxed so we can assess initially to see if there's any obvious scars, any abnormal pulsations or any visible masses. Thankfully that's not the case here, but when I say visible masses, we also need to pay attention to the possibility of hernia, in which case we could be seeing hernias above, around or even within the umbilicus, and looking further down we may have evidence of inguinal hernias, or if there's been any evidence of surgery before, we can have incisional hernias as well. Any of these would need to be documented. We're going to start off just by palpating lightly over the abdomen, keeping in mind that we're going to be doing so over the 9 regions. Before we start that though, we need to confirm once again that there's no pain to the patient. Is there any pain or discomfort on your stomach?
No.
In terms of this palpation, we'd make sure if there was, we're palpating the painful region last. When it comes to palpating the abdomen, we want to do it twice, giving 2 different sort of looks, if you will. So to start off with, I'm going to use the flat of my hand and I'm palpating up and down, not trying to push very deeply. At this initial overview, all I'm doing is seeing if there's any signs of pain or discomfort when I'm doing this palpation. And as I'm doing so, I'm feeling for any guarding. So when I press down over the abdomen, does the abdominal wall contract, which might suggest that there is irritation to the peritoneum underneath. Even if there is pain there, I'm going to be very cautious, but we're going to then go on to a slightly deeper palpation, now using 2 hands. So I'm going to go down and round, down and round, down and round. And at this point, I'm not looking for discomfort, although again I'll be paying very much attention to it. I'm trying to see if I can find any masses, hence the pushing down and around would allow your hands to come off the sides of a mass, allowing you to start identifying it. At this point, we can lean over to push with one hand and push with the other behind to try and identify the kidneys where we're ballotting it. When it comes to ballotting the kidneys, we're going to use both hands. We're going to press down on the abdomen with one hand. This is our detector, if you will, and then we're going to press up, trying to flip the kidney, this retroperitoneal organ, so that it will move and impact, or we'll feel it on our detector hand that is on the abdomen. And we'll do the same again on the opposite side as well, trying to ballot, flip the kidney up so it bounces between the 2 hands. And being honest, I've only ever ballotted the kidney at medical school when we've had patients with polycystic kidney disease. At no other point in my clinical career have I actually encountered the kidneys. With no obvious issues found, we then want to look for some of the specific organs. So we can try and find the bladder, so palpating with the flat of the hand, the index finger leading, and we're just going to go down towards the pelvis to see whether or not we can feel any swellings to the bladder. This is impalpable at the moment, but we will go on shortly to percuss over the bladder as well. So in terms of examining for the liver and the spleen, the liver will extend down towards the right iliac fossa. The spleen will also extend to the right iliac fossa. So in terms of doing the palpation here, we need to start off with our hands right down in the right iliac fossa, making sure that our little finger is pressing on the pelvis. We're going to examine with the leading edge of our finger, pushing in as the patient breathes in and then releasing when they breathe out. So deep breath in for me. And then out. And on the out, I'm going to move forwards, in, and out. Same again, in, and out. All the way up to the costal margin, in, and out. And as you see, if the patient breathes in, the liver will be pushed down by the lungs and will impact on my finger, so I then feel it. And as we can see here, I'm able to put my fingers quite far up to the costal margin, probably about 1 centimetre or so in, without causing any significant discomfort. And we want to see if I can feel the patient's liver coming down with each breath to brush against the side of my fingers. We then move to looking for the spleen, and the spleen will enlarge from the left upper quadrant down to the right lower quadrant. And again, making sure your fingers are right down in that side there. That might seem a little bit, OTT. However, as a medical student, I missed an incredibly enlarged spleen because I started a little bit too far across the abdomen. So make sure you're all the way down to the right iliac fossa. Again, deep breath in and out. 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 And with both the liver and the spleen, we're going to feel the organ touching onto our fingertips, and we're going to measure any enlargement in number of finger breadths. So it's normal to have sort of 1 to 2 finger breadths of liver palpable by the costal margin. Anything greater than that, and we've probably got a problem in the liver, and we need to look a little bit further. When we do encounter the liver edge, it's also worthwhile to highlight what we can feel. Is it a smooth liver? Is it a rough, nodular liver? Is it hard and craggy? All of those might give us an idea about what we're going to find underneath. We need to percuss over the abdomen as well. For the spleen, we should be finding a dull area in the mid-axillary line between the 9th and 11th ribs. So we're going to put our fingers on the chest, percussing between the ribs with striking directly over the distal interphalangeal joint. So there's a slight change in tone there, and definitely there. So we've not found an enlarged spleen on palpation, and we similarly haven't found it on percussion. We then need to percuss over the liver. The liver will enlarge from the 5th intercostal space mid-clavicular line downwards. So we're going to start to percuss from here. So we can find the manubrosternal joint, so the 2nd intercostal space, 3rd, 4th, 5th. We're going to bring to the mid-clavicular and then percussing again, striking over the distal phalanx. And we can hear the change in tone there. So again, we've got no extension of the liver up into the chest. In terms of percussing out the various organs, we also need to percuss down to the bladder. So we're going to start off at the umbilicus, keep on going down to see if we can find a change from resonant to dull, which may indicate the presence of the bladder. Okay. So in terms of percussing the abdomen, we've got the 9 regions, the same areas that we palpated. I'm going to put the hand flat on the chest and I'm going to strike over the distal phalanx. And we should get a nice resonant sound as we're going around those areas. And we've got a nice resonant tone throughout. If we found a dullness, that may indicate feces, it may indicate an obstruction, and we want to try and put that together with the other information we'd had from the clinical examination so far. Conversely, if we found a hyperresonant area, so booming on percussion, that may indicate an obstruction with a dilation behind that obstruction as bowel gas is building up. To finish off focal examination of the abdomen, we also want to push directly over the umbilicus to see if there is an expansile mass. If there was, then we'd find that the fingers were pushed apart as our hands were on the stomach there. We also need to check the hernial orifices. Ideally, we'd want to have the patient exposed completely, but in the vast majority of situations, that's not appropriate. We're going to press down on the inside of the pelvis towards the base and have the patient turn away from us and have them cough. And I can't feel a cough impulse to either hand, so I feel it's highly unlikely that we've got any signs of a hernia here, although we can visually inspect those hernial orifices and also examine the external genitalia. We also need to auscultate the abdomen. Now, there is some variation internationally about where the auscultation is done in the examination. Certainly in the UK, we auscultate at the end of our palpation and percussion. In discussions I've had, people have queried whether or not auscultation at the end of the examination reduces the clinical significance. However, all of the clinical skills research suggests actually auscultation in the abdomen is a very weak sign, and 50% of highly skilled consultants' clinical impressions from auscultation aren't borne out on radiology. So with that, there's not been significant evidence to say that the timing of your auscultation has any bearing on the findings. So if your institution is advising you to auscultate early on in your examination, That is what your institution is requesting, and you should follow that protocol. However, if you're in the UK and your institution is saying to auscultate at the end, similarly, that won't affect the clinical outcome. So in terms of auscultating the abdomen, we need to listen directly over the umbilicus, and we can listen here for up to 2 minutes in terms of trying to identify bowel sounds. We also need to listen slightly superior to the umbilicus to see if there's any bruise that we might associate with an aortic aneurysm. And similarly, that aneurysm may then go on to affect the kidneys. So we're going to listen 2 to 3 centimetres laterally and superior to the umbilicus on both sides to see whether or not there's any evidence of a renal bruit there as well. And I can't hear any unusual sounds by the side of the stomach. Right, so what we're going to do now is I'm going to see if there's any signs of fluid in your stomach. So I'm just going to percuss across. Okay, so we've got a nice change there. If you could roll towards me. Okay. And we're just going to let that sit for 10 seconds. And we're going to do that again. Okay, that's fine. So there's no change in note there. It is important when doing a clinical examination that you're covering all areas. So that is going to mean examining the feet as well. Bear in mind, we'll get the same appearances on the feet as we would on the hands. That also allows us to check for edema at the same point. So I'm going to press with 3 fingers over this credit card area-shaped piece of tibia, and I'm making sure I'm pressing with 10 millimeters of mercury, so my fingers have turned white. We'll do that for 10 seconds and then see if there's any swelling there. And if I could just get you to sit up for me so I can just have a quick press at your back. And there's no issues there, super. So we haven't found any abnormalities on that examination. We will see if there's any urine samples that we can check. We'll do a look at a stool sample and also a rectal examination, if that's okay, along with checking the external genitalia and for any lymph nodes. That completes our deep dive into the abdominal examination. I hope this has been useful for you. If you've got any questions, please put them in the comments down below and we'll try and help you out. If you'd be kind enough to like the video, it basically tells the YouTube algorithm that we're here. And if you subscribe to the channel, then you'll both get updates when we do the next video, but you'll also be able to engage with us when we put things up in the community section. With that in mind, take care and we'll see you in the next one. Cheerio.